no obvious reason to have a microcystic anymore. It's the next best investigation. William says duplex, as though that's different from Doppler. It's not really, just has color and two phases. Scope. Excellent. Right. The next step is a colonoscopy. Alright, guys. The next step is a scope. This patient likely has a pelvic tumor causing venous compression, likely has a colon cancer somewhere, causing venous compression and also causing some occult bleeding. Excellent. Great. So that is that. That's a by the way. But anyway, so these are your secondary causes. Just to understand that a pelvic tumor could cause varicose veins, or it could even cause a deep vein thrombosis because of stasis of blood flow. All right. But what is critically important for you all to understand about varicose veins is this thing called a C classification. CEAP. C for clinical, E for etiological, A for anatomical, P for pathophysiological. All right. Then you have etiology. It could be congenital, it could be primary, it could be secondary, it could have no obvious etiology. Anatomically wise, it could be superficial, it could be deep, it could be perforator incompetence. Pathophysiologically, it could be due to reflux of blood, it could be because of obstruction, it could be because of both, or no pathophysiology identified. We need to know what CEAP stands for: clinical, etiological, anatomical, and pathophysiological. So that's one you need to know for your OSCE, what CEAP stands for. The other thing you need to know about CEAP is what the C actually has in it. The C for your clinical manifestations range from C0 to C6R. And this is actually the most updated form of your C in terms of your CEAP classification. And you all just need to learn this off. I cannot explain this to you. C0 is where you have no signs of venous disease. C1 is where you have telangiectasias. C2, the patient has obvious varicosities. C2R is recurrent varicosities. C3 is where they have venous edema. And then you have to pay attention to C4. C4 is where you have changes in the skin as a result of your venous disease. That could be pigmentation, it could be lipodermatosclerosis or atrophy blanche, or it could be corona phlebectasia. All right. C5 is where you have a heel ulcer, and C6 is where the patient has an active venous ulcer. So of course it goes from 0 to 6 in worsening severity. C6 being your worst, C0 being no visible disease, and everything in between. Please just learn your CEAP classification. If you get a varicose veins in your OSCE, as a matter of fact, you would hope you get a varicose veins. I got varicose veins for my surgery OSCE, and I got total in that station because it's very easy. They usually just ask you about the CEAP classification and the tourniquet test. Okay? And well, everything else we have here is just additional information that can be asked as well. All right? But definitely, once you can rattle out the CEAP classification on the top of your head, the examiner is going to be very impressed. And you need to now look at your patient and determine which CEAP classification is it. And so this picture has a nice little synopsis of what it looks like. So C3 is where you have venous edema, C1 is the telangiectasia, C2 is the obvious varicosities, C4 is where you have skin changes with the inverted champagne bottle appearance, which you all should know about. C5 is a healed ulcer, and C6 is an active venous ulcer. And well, I mean, it's in the image. I was going to ask you all, okay, I'm still going to ask you all, where is it most commonly located? Where is a venous ulcer most commonly located, guys? The gator region, right? So the gator region, which is the region of the medial margin, it's fantastic. Anyways, closer to exam, I will talk about dry gangrene and ischemic. So the ischemia, of course, in terms of arterial disease, you start to see, I think I have pictures here. I do, right? So this is in keeping with, this is going to be critical limb ischemia, right? So this patient is having distal, distal dry gangrene and a lot of trophic changes, very loss of hair and shiny skin. So go through the guide for these things, right, guys? This is less MCQ, this is more OSCE, all right? So your CEAP classification, you have to know. It's self-explanatory, just learn it off. Good. What I want to ask you all about is Okay, so I'm going to show you all some images and you're going to tell me what this is. So what is this here? How would you describe this? Fantastic, right? So this is a corona radiata or corona phlebitis. So it's like a crown pattern appearance. Yeah, this is corona phlebitis. Which C stage is this? See, see, Anton, 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 come. Anton, Anton, Anton. Okay, you're excused, you're excused, right? Right? Because C2, remember, is just varicose veins. What is this here? Inverted champagne bottle appearance suggestive of? What's the name of this? Lipodermato. Dermatosis, Brittany? Right. Lipodermatosclerosis, right? I want you all to spell out the word. So it's lipodermatosclerosis, right? Good. And this here is actually a combination of two. What does this look like? A trophy blanche, right? And you have to put, as Dr. Harry Noran to say, you have to put a trophy blanche. You have to put the French in it. Yeah, looking like the patient had a heel ulcer. It had looking like they have a heel ulcer here, William. Right? So it's a trophy blanche. It's a BB ulcer somewhere. Right? Good. So be able to recognize all of them. You could just Google images and look at all of them, but those are the three ones that come in the exam: a lipodermatosclerosis, some corona radiata, or atrophy blanche, and well, of course, obvious just C2, which is just obvious varicose veins. Okay, so know what all of them look like, and please know your C classification. It is self-explanatory, easy marks. Just learn it all. All right. So those are that. Um, Safina varix. Safina varix is actually a varicosity in the groin region at the safina femoral junction, and this has a positive cough impulse. So safina varix is a differentiation for your groin swellings. And I know you all have food in the exam. Do you all want a surgery OSCE? Christina was asking me to do a surgery OSCE. You all want a surgery OSCE class? Right. Right. I will see. I will see. Yeah, I will see. I will see. All right, cool. I'll see, guys. I'll see. I love you guys. Just how I working on things, I'll be real hard. But anyways, yeah. So Safina Varix is one of the differentials for groin swelling. So he's asked about it in the hernia exam. Okay. So sleep classification, I definitely need to know. So that's self-explanatory. What is this? What is this? Celine. Klippel-Trenaunay syndrome. What's the triad for Klippel-Trenaunay syndrome? It is a baby. It's a baby, William. What is the triad of Klippel-Trenaunay syndrome? Port Weinstein. One. Venous malformation. Two. It has varicose veins. And limb hypertrophy, usually of how many limbs? All? One. Yeah, correct, right? So guys, Klippel-Trenaunay syndrome is something that is asked about many times in association with Trenaunay. Guys, I probably spelled this wrong, right? But Klippel-Trenaunay syndrome is asked in tandem with varicose veins because it has a triad. It's a congenital cause of venous insufficiency, varicose veins. So the child is usually born, the patient is born and grows up with varicose veins. Varicosities are usually seen in older patients who, had a lot of walking, a lot of prolonged standing, etc. So it's varicose veins with limb hypertrophy, usually of one limb, right? Usually of one limb. And the patient also has a port Weinstein. This is commonly asked in anything. It could come in MCQ as well. All right. But when you're speaking about varicose veins, you have to speak about Klippel-Trenaunay syndrome. Just like when you're speaking about limb ischemia, you have to speak about Lariche syndrome. You have to know about this. All right. Excellent. So good job, Celine. You all have heard about that before, right? I know Celine gave the answer, but I'm just asking how many of you all have heard of that before. Okay, good. Fantastic. All right, so now you see a little picture. Good, Julian. Well, now you know it. Add it to your compendium of new things learned. So that's good. Good, guys. The tests that suggest venous insufficiency would be the Trendelenburg test, Perthes, the TAP test, and the tourniquet test. Which one of these suggests venous insufficiency in the setting of deep vein thrombosis? Excellent. Right, so the Perthes test. So your Perthes test suggests that your venous insufficiency is likely due to DVT. All right, and that's why you probably have a varicose veins. Um, Trendelenburg 1 and 2 are kind of like tourniquet, but I'll send you all videos on the differences between them, okay? Self-explanatory as well. But for sure, you need to know about the tourniquet test, its interpretation, and how to perform it. Okay? So there's a couple of videos on YouTube that explain that pretty well. Good. So when it comes to venous insufficiency, guys, the investigation of choice will be ultrasound, and it's usually a Doppler ultrasound or duplex. We have something called ascending phlebography, which you all don't need to know about, or you could do a venogram. All right, it could be CT or MR. Usually MR venogram is preferred, but by far anything to do with the veins, you want to ultrasound it. Okay, if you have to pop a IV access on a heart stick patient, you're gonna ultrasound. All right, the veins usually are compressible. If you have a vein that is non-compressible on ultrasound, what does that suggest? You use the probe and it's not compressing, deep vein thrombosis. Fantastic. Good. So the other thing, we almost done with venous insufficiency here. As I said, it's hardly anything to teach from an MCQ perspective, but I'm showing you all what you need to know for OSCE. Would be the complications of venous insufficiency, okay? So very commonly they ask you about a Marjolins ulcer. All right, so what they ask about, and this is where they ask about Cushing's ulcer. Seen this MCQ come twice last year for both June and December. Curling's ulcer, Marjolin's ulcer. I just need to know about these eponymous ulcers. All right. So your Cushing's ulcer, Curling's, and Marjolin's. So who do we see Cushing's ulcer in, guys? Just remind me one more time. All right. So patients with increased ICP and head trauma. Good. Curling's ulcer is seen in who? Burns and stress. And a Marjolin's ulcer. So a Marjolin's ulcer is where you have it's actually a cancer, and it is where the patient had previously traumatized or inflamed skin, and the cancer is very, very bad. It looks very, very bad, right? Damn it. Guys, just Google an image of a Marjolin's ulcer. Okay? So a Marjolin's ulcer is a complication of venous insufficiency. What it is an aggressive, very ulcerating squamous cell cancer. So it's a squamous cell carcinoma in the setting of in the region of previously traumatized skin. All right. So Marjolin's ulcer is something you need to know about. It's a complication of venous insufficiency, and I want you to Google some images of it. Okay. So as we hear, just as a by the way, if a patient has a dermatological skin condition, And let's say the patient has psoriasis, and the psoriasis only affects the left elbow. But when they hit their right elbow, that region that previously had no lesions, after the trauma, that region develops lesions. What is that called from a dermatology perspective? Kebner's phenomenon. Fantastic. And so you need to know about Kebner's phenomenon, right? So Kebner's phenomenon, you need to know the dermatological conditions. And usually I remember it as patient Kebner, very strange man with something disease or something like that. And the P is psoriasis, the K is Kaposi sarcoma, etc., etc. But we have a class on wound games, that's fine. So that's just as a by the way. But a Marjolin's ulcer, guys, you need to know about that. And these are all the other complications of venous insufficiency. Non-healing ulcers, lipodermatosclerosis. Of course, it could bleed. You could have osteitis, osteomyelitis, etc. Very self-explanatory. Okay. And the last thing, and this is really where your questions come, for venous insufficiency in the MCQs, they simply ask you the principles of management. Okay. So, your management of a venous ulcer is to massage, elevate the feet above the level of the heart, exercise, etc. And in the case of the ulcer, management of varicose veins, sorry, massage the area, elevate the feet above the level of the heart. You could use your compression stockings, etc. In the case of an ulcer, you use antibiotics, bandages, clean and dressing. And so this concept is also applied to OSCE. But from an MCQ perspective, what they love to ask you about is the treatment. Okay? And the treatment, um, the gold standard and definitive treatment is surgery. However, for varicose veins or venous insufficiency, surgery is reserved if the patient's life is being affected or if the patient wishes because of severe disfigurement and cosmesis. So if they have impaired lifestyle, social interactions, and so on, then our gold standard of treatment is our definitive treatment, which is surgery. Okay? So the modalities of surgery are what they like to ask you, and it's just concepts. You can do venous vein stripping, you can do stab avulsion phlebectomy, you can do foam sclerotherapy, or endovenous laser ablation. So these are the four modalities that you just have to know and associated with varicose veins. They are not used for acute limb ischemia or peripheral artery disease. So don't see a patient with varicose veins and say you're going to do ETLA or you're going to do bypass surgery or you're going to do Bugatti embolectomy. Okay? If you see a patient with varicose veins, you're going to do stab avulsion, vein stripping, or laser ablation or sclerotherapy. All right? So those are the principles of management. Daflon. What is Daflon, William? You know what Daflon is? Daflon has a phosphodiesterase inhibitor. So where have we seen PDE inhibitors before? In which of the conditions? Yeah. So you know what drug Daflon is? Yeah, you could Google it. Right. So Daflon has a unique indication, but usually, even though it has a what Daflon is again? Daflon. Di diosmin something. Yeah. So McGill is a pharmacist, so she's telling me. So it has a very interesting way that it works. Can't remember exactly how, but Daflon is actually used in vascular disease, and it is also has a very strong role in venous insufficiency as well. Yeah, so usually they put the patient on Daflon, but it the mechanism of action, because it's diosmin something, hesperidin, yeah, diosmin hesperidin, right? Um, So it's used in venous insufficiency, right? Can't remember exactly how that works. I haven't done that in a long time. I think the hesperidin part is the PDE inhibitor. So yeah, you could use Daflon as your medical management as well, right? Um, But that is something that general surgery isn't going to ask. Okay? Could guarantee you. Good. So those are concepts of venous insufficiency. Your conservative management will also include things like weight loss and exercise, etc. All right. Any questions on venous insufficiency? I know I kind of skimmed it, but I kind of skimmed it, pointing out what you all need to know mainly from an OSCE perspective. And I'll see how I feel about that OSCE class thing. I like to help you all out. Good. So know about these concepts, and I'll show you a little thing about tourniquet tests and so on. So if no questions, let's go on to the um, MCQs, which are very easy, and they usually are where venous insufficiency is concerned. So, right, so sclerotherapy is not surgery, all right? And I think I had it here if I wanted to. Let me make that clear. Kind of had it kind of bad here. So sclerotherapy is not surgery, okay? Your surgeries are this, and you can also do laser ablation. But these two are your surgical approaches, and so these two would be a gold standard. Depending on the level of occlusion and so on, that is beyond the scope of what you need to know for MBBS, okay? Nice. So this is a 41-year-old woman diagnosed with varicose veins in the left leg, presenting to clinic, 2-month history of severe pain in the left leg on prolonged standing. She's obese, and her working and social lifestyle are affected. What is the most effective treatment for this patient? And that will be surgery. Okay? Because she has social impairment and it's affecting her daily life, in her case, you are not going to opt for conservative management. The most effective treatment for her, as you all would have rightly said, would have been surgery. So excellent. Right, DVT prophylaxis, drug of choice, low molecular weight heparin, very easy. Tourniquet test, positive tourniquet test suggests varicose veins, very easy. Okay, so this was just a little thing to show you all about varicose veins, but I want you all to go through the guide and prepare for your venous insufficiency from a vascular OSCE standpoint. Okay, the guide has everything you need to know about what they like to ask you. And coming closer to the exams, I'll ask you a little more questions. All right. Any questions though on venous insufficiency? We're gonna finish up with our last topic now. I'll answer number 11. All right, good. Very easy, very easy. And number 11 is yes. This woman has claudication, intermittent claudication. She's a smoker with hyperlipidemia, and you want to discuss her treatment options. Well, we said for intermittent claudication, we do not need to do surgery, so we're not going to do angioplasty, we're not going to do bypass. Obviously, it's claudication, we do not need to amputate her. All right? So the best treatment option for this patient would be to start DAPT actually. We could do dual, well, we could do single antiplatelet because she's only having claudication. If it was critical limb ischemia, we could start off with DAPT. But in this case, really and truly, most patients with peripheral arterial disease, with intermittent claudication, a lot of them are actually on dual antiplatelet therapy. All right. Um, and well, E is just wrong. Okay. We need to optimize atherosclerosis and minimize the risk of clotting. Good. So very simple. And the last set of questions are on this big bad boy. Very easy topic. And I'm going to show you what you need. So guys, let's finish up the class. Answers to number 12, please. Answers to number 12, please. Good. Number 13. Answers to number 13, please. Answers to number 13. Great. Answers to answers to number 14. Answers to number 14, please. Answers to number 14. Good. Answers to number 15. Answers to number 15, please. Answers to number 15. 15 goes together with 16. Great. Answers to number 16, which is based on number 15. Answers to number 16, please. Fantastic. Answers to number 17. Answers to number 17. Okay, so we have a couple of discrepancies there. Answers to number 18. Answers to number 18. This is always happen. Let's answer like 15, 16, 17 real quick. Pop, 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 and then I have delays in answers for number 18. That's funny. And even if you're not sure, I could kind of make a guess, right? Good. Let's answer these last two here. Answers to number 19. Number 19 first. Answers to number 19. Fantastic. And answers to number 20, please. Answers to number 20. Okay, good. Fantastic. So now we're just going to teach when we was linked with berry aneurysm. Talking about what medical condition on your abdominal exam. Good, good, Christina. Fantastic. Yeah, good. And what else was adult polycystic kidney disease linked with? You said three things. Right, hepatic cyst, hypertension, and berry aneurysms. Fantastic. So you always pay attention, man. Good, good. That is wonderful. Right. So now, guys, we're gonna teach aneurysms, and then we'll just answer the other by the way questions together. Okay. So we're gonna teach triple A. Triple A is very, very easy. Gonna make your life very easy and tell you what you need. Okay. So an abdominal aortic aneurysm. Abdominal aortic aneurysm. These are first and foremost true aneurysms. Good. True aneurysms means that all the layers of the blood vessel wall form the aneurysm. So this is not a false aneurysm. A false aneurysm is where you have like this, you have a breach in the blood vessel wall. So let's say this is the blood vessel wall and the blood pools here. This is a false aneurysm here. Okay, this is the blood vessel. This is a false aneurysm. This is a shit, shit. This this is a true aneurysm. Okay, this a little bit. Right? So the actual blood vessel wall, all layers are involved and it's actually dilated, right? So AAAs tend to be true aneurysms. The false aneurysms are seen in aortic dissection. So when you have a tear within the intimal lumen, within the intima, sorry, of the blood vessel, it leads to pooling of the blood within here, and that leads to what looks like an aneurysm, looks like a dilation on imaging, but it's not. Right? So a triple A, when you speak about abdominal aortic aneurysms, these are true aneurysms involving all layers of the blood vessel wall. All right. So what is the most common location of abdominal aortic aneurysm? The most common location is infrarenal. All right, infrarenal. Good. Infrarenal is the most common location of your triple A's. So that's that. So what does that mean? That means that you have your aorta coming here. You're gonna have some blood vessels coming off here. I have your aorta coming down here. You're gonna have some blood vessels coming down here. These vessels are your renal arteries coming off your abdominal aorta. And these renal arteries is how you classify the location of your AAA. So this here, this aneurysm here, this is infrarenal, and this is the most common location. You can have suprarenal, where you have an aneurysm here. You can have pararenal, which is the aneurysm kind of here involving, and you can have juxtarenal, which is just abutting the renal arteries. The most common, so you have suprarenal, you have pararenal, and you have juxtarenal as well, all in relationship to the renal artery, but the most common is infrarenal Tripoli. All right, so that's the most common location. So that's one thing there that you need to know. Good. What else do you need to know about AAA? Well, the shape of them, AAA tends to be, this is just a pathology, they tend to be fusiform in shape, right, rather than saccular. So fusiform is where kind of like this, right, where it's more longitudinal, whereas saccular is more bulging like this, right? So they tend to be like this, which is fusiform. Good? So that's that. So that's AAA. So from a clinical standpoint, what you definitely need to know about abdominal aortic aneurysms are the risk factors. Okay, guys, the risk factors are critical to note. All right, so the age is one, older age, more than 60 usually. Smoking is one. Hypertension, of course. A family history is a big risk factor. Atherosclerosis, Connective tissue diseases such as Marfan's and Ehlers-Danlos, right? Collagen vascular diseases such as lupus, um, of course, infectious, right? Infective. And the infective causes include, well, in this case of AAA, in the case of AAA, abdominal aortic aneurysm, the infections here would be a dysentery infections, so Salmonella and Shigella, the dysentery infections. And, well, if it was thoracic, it would be syphilitic, okay? Syphilitic. And this will be tertiary syphilis. But we're not talking about this here. So for this, all intents and purposes, we're speaking about Salmonella and Shigella as the infective risk factors for AAA. All right. So these are the risk factors for AAA, and you need to know them well. Older age, smoking, high blood pressure, family history of it, atherosclerosis, connective tissue disease, collagen vascular disease, and infection. So what that means is if you see everything here that is here, but you see diabetes mellitus, okay, then the answer there, which one of these is not a risk factor, out of all of these, the answer will be diabetes mellitus. Okay? Yes, diabetes mellitus can lead to atherosclerosis and increase your risk, but I'm just telling you what the MCQ comes like. Okay? So that's that. What else do you need to know about AAA, abdominal aortic aneurysm? Well, you need to know about the clinical features. So what I want you all to know about abdominal aortic aneurysm is that a lot of patients are asymptomatic. This is actually the most common presentation. It is usually an incidental finding on imaging. So they had imaging for some other reason, probably had some belly pain for some other reason, some pancreatitis, something jacking up the belly, and they do imaging and they notice, A, they actually have a dilated abdominal aorta infrarenally, and they're saying this is a triple E. So the clinical presentation is usually an incidental finding in most cases. All right. The other clinical features, however, are particularly important to know. So we all know an abdominal aortic aneurysm presents as a pulsatile that is, it has a pulse, and that is expansile, that is your fingers spread apart when you palpate it with an audible breathe. Okay? So a pulsatile expansile mass, it's an audible breathe, of course, in the region of the abdominal aorta. Duh. Right? So this is your classic presentation. So a patient has a pulsatile expansile mass with an audible bruit. That is an abdominal aortic aneurysm that warrants serious investigation because you might have to repair this. You'll see the criteria to repair. Other clinical features of a triple A, well, let's do it like this. So you have your aneurysm. Let's draw it a little circular here. You have your aneurysm here, right? The aneurysm here tends to be kind of infrarenal, all right? So what could happen? Your aneurysm could do so, and it can compress the arteries. So you can have compression of structures. So compression of structures, right? Somewhere in this region could be a kidney bean, and of course, somewhere in this region could be a ureters. So the aneurysm could compress here as well. So it could compress artery, so it could compress the renal artery, and lead to renal hypoperfusion. It could compress your ureter and lead to obstructive uropathy, right? So it could compress the artery, it could compress the ureter. What else could happen is you have here, I just draw this is somebody back, the spine here, the spine, the aneurysm could erode into the spine. So it could erode into the spine, right? So you could have erosion into the spine. And in this case, these patients present with back pain, right? So you could have compression of the renal artery, the ureters. You could have erosion into the spine causing back pain, all right? You could have blood pooling here. If blood pools here and this blood pools here, you have what? Some thrombi forming. This thrombus could break off and it could have peripheral embolization, all right? So you could have peripheral embolization as well, right? And this could go on to, of course, occlude your leg and lead to acute limb ischemia. It could lead to mesenteric ischemia, or it could lead to trash foot. And we'll talk a little bit about trash feet. Okay, we'll talk a little bit about trash feet. So the other clinical features or complications, I should say, so it presents as an abdominal mass that is pulsatile and expansile, but it could compress and obstruct the renal artery. It could compress and obstruct ureter, leading to obstructive uropathy or renal hypoperfusion, and therefore an acute kidney injury as a result of renal hypoperfusion. It could erode into a vertebra and lead to back pain because it's eroding into your vertebra. And of course, you could have embolization if you have stasis of blood within the region of the aneurysm, leading to peripheral artery embolization. Okay, this could also erode into your veins, and if it erodes into your veins, then you have a arteriovenous fistula. So it could erode into the inferior vena cava, right? So you could have a arteriovenous fistula. It could also erode into, we'll put this in yellow, a small bowel. So this will be called a aortoenteric fistula if it goes into a bowel, aortoenteric fistula, and this will be called a aortocaval because it's the vena cava, right? So an aortocaval fistula, right? So you could have compression of the renal arteries, compression of the ureters, you could have erosion into the vertebra, erosion into the duodenum or small bowel, erosion into the vena cava, peripheral embolization of vessels. All right, embolization of a clot. Okay, but of course, the big bad thing, my God, about your AAA is that this thing can rupture. Okay, this is a big fair complication of abdominal aortic aneurysm. A rupture AAA usually presents as an acute abdomen. Right? This is your acute abdomen. So what are your findings of a ruptured AAA? A ruptured AAA would present as very severe abdomen pain, radiating to your back, and the patient could have had a history of a pulsatile mass and presents with that pulsatile mass, and of course, hemodynamic instability. Because why? Well, your whole aorta rupture, you have a bus vessel in your belly, your blood pressure is going to drop, your heart rate is going to go up. These patients will develop a hypovolemic shock. Rupture AAA has a high risk of death. We'll talk a little bit about what that risk is. Okay, so the complications would be embolization, compression of neighboring structures, erosion into the vertebra, the vena cava, as well as the duodenum, and of course, rupture. All right, so that's what you need to know there about AAA. The other things you need to know about AAA would be our investigations of AAA. So your first line investigation is actually an ultrasound of the abdomen, and you'll see something called the yin yang sign, which I think I have on my guide. Do I have this? I'll show you. Right? Yin yang sign. This is your first line investigation of a abdominal aortic aneurysm. However, it is not the most accurate test. The most accurate test is actually CT or MRI, and usually it's contrast enhanced CT of the abdomen, right? So CT abdo with contrast. In the instance that you have a patient who you have diagnosed with a AAA, abdominal aortic aneurysm, ultrasound is the investigation of choice for monitoring. And I think most of you all would have gotten that answer. Okay, so ultrasound is the investigation of choice for monitoring. The CT scan is preferred, it is the most accurate because it will be able to, of course, tell you the exact location in the abdomen. It will be able to tell you the size. It will be able to tell you it's not leaking. Actually, let me write this because you should know these criteria. So we said ultrasound is first line investigation. CT scan is gold standard, however, and the CT is gold standard because it could tell you the size, which is critically important, the location. It can rule out a leaking aneurysm. It could determine the type, and of course, it could rule out other pathology. And these are the reasons that the CT is your best investigation, but it is not used to monitor your patients who you know have an aneurysm. If you know they have an aneurysm and you want to monitor them, then the best step to monitor is ultrasound. Okay, right? So that's that. And the last couple of things about AAA is here. That is the indications for repair. So the indications, okay, let me just do this different, right? This is the management. So the management of AAA depends on if it is non-ruptured or unruptured, whatever you want to call it, versus if it is ruptured. Okay, if it is ruptured, obviously a ruptured AAA, most patients die, and more than 90% of patients will die with a ruptured AAA. How it works is 50% will die when the AAA ruptures, 50% of that remaining 50% will die on table, and then another 50% of that 50% who had surgery will die post-operatively. So approximately 50% plus 50% of 50% plus 50% of 25%, which will approximately give you only about a 10% survival. All right. So if it's ruptured, it has a very high mortality rate. Okay. So to treat a ruptured AAA, however, of course, this will lead to shock. So you have to stabilize the patient. And we know how to do that. IV fluids, yada, 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 right? ABCs plus IV fluids. We know how to stabilize our patient. Obviously, this is the first thing you're going to do. We went through this 1,000,001 times. Next thing is, what are the types of repair that you're going to do? So there are, what exact repair you're going to do? So there are two repairs now, and that is the open repair, which remains the gold standard, or there's also something called EVAR, right? Which is your endovascular repair. So this is still the gold standard of management. This year is a reliable alternative, meaning that you can still choose this over the open repair. The reason the open repair remains the gold standard is because you have a better view of the anatomy. And so it allows for a wider range of exploration and so on. But the endovascular repair has a reduced risk of morbidity and shorter hospital stay. And so in a patient who probably was going to die anyway, you want them, if you are going to save them, you want their hospital stay to be shorter. So that's why EVAR is actually a suitable alternative. But the go-to for a ruptured triple A, the gold standard is still open repair. All right, EVAR has its place, and many surgeons will do EVAR. Many surgeons will do open repair. Okay, but open repair still remains preferred over EVAR, even though EVAR or endovascular repair is a very good alternative. All right, good. When you do open repair, just remember that you have to use a graft, and the graft is usually a Dacron or PTFE mesh. Okay, all right. So it's usually a synthetic graft. Good. So that's how we would treat a ruptured AAA. What about a non-ruptured AAA? Well, a non-ruptured AAA has certain indications for you to repair it. And this is critical to know. All right? The indications for repairing a non-ruptured AAA will depend on the size, the growth rate, and the symptoms. Okay? So it's three things: the size of the aneurysm, how fast it's growing, and if the patient is having symptoms. All right? And so The size is more than 5 centimeters in women. So more than 5 centimeters in women and more than 5.5 centimeters in men. All right. The growth rate is an increase in the diameter by more than 1 centimeter per year. So if you found it was 3 centimeters last year and it is 4.1 centimeters this year, you can operate. And of course, if the patient has symptoms, so if they have things like back pain, if they have embolization, any of the complications, of course, you would repair. All right. So it's based on the size, the growth rate, and the symptoms. That's what's going to determine your repair. And in this case, what is it? Just one of those? Yeah, anyone, Jody. Anyone can be met. Yeah, you don't need to meet all. Anyone can be met. If that patient having symptoms, that rupture is that aneurysm is going to rupture, and so you want to repair that. If that aneurysm is growing too fast, it is going to rupture, and of course, if it's already big, there's a higher risk of rupture. Okay, so any one of those criteria, you can repair it. And when you do this repair for an unruptured AAA, the repair is not done like you would um with with EVAR and so on. It is called an aneurysmorraphy, which is a long, complicated procedure. And I'm not a surgeon to explain to you how an aneurysmorraphy works, right? So just know that this is the standard of treatment for unruptured AAA. Okay, aneurysmorraphy. Good. Last thing for AAA would be the complications of procedures. All right. So the complications for the procedures of a AAA, this could be either repair of unruptured or ruptured. But the complications of your surgery would be a heart attack, stroke. Very, very importantly, is acute limb ischemia plus or minus trash foot. This one you need to know. All right. So trash feet is where when you have the aneurysm here, but you had a clot, this clot now breaks off and it goes to your limb, right? It goes to the limb. This clot breaks off, goes to the limb, and it goes as many, many small clots. And so you have a clot here, clot here, clot here, clot here. So it breaks off as multiple small microemboli. And these microemboli are going to occlude multiple vessels in the feet. And this is called trash feet, right? So trash feet is seen as a complication of the aneurysm itself or of the aneurysm repair. If you break off any thrombus, it could, of course, dislodge as microemboli and lead to trash feet. So this is a very high yield thing to know about AAA. Right? Oh my gosh. I do not know what I did, how I did that. Okay, I think it's okay. Figured it out. Right. Good. Right. This is cool. Look how this looks. This actually looks pretty cool. Right? Other complications of repair include acute kidney injury, because I mean, look at where the vessels is, right? Look at where the aneurysm is. So you could have hyperperfusion to the kidney, acute kidney surgery, acute kidney injury. I'm getting tired, which means you all are tired. And anterior spinal artery syndrome, which you all should have watched Ninja Nerd's video and see about anterior spinal artery syndrome and know that an aortic dissection or an aortic aneurysm repair is one of the most common causes of anterior spinal artery syndrome. So we're not going to go into that now. It's late. Good. That's AAA, literally. Whew. I'm tired. Any questions on abdominal aortic aneurysm? Something I was going to show you all in the guide. So, okay, right? So you have suprarenal, pararenal, juxtarenal, and infrarenal. Infrarenal is the most common. Right, I was going to show you all the yin-yang sign. So this is the yin-yang sign. This suggests abdominal aorta, so your best first step is ultrasound of the abdomen. Right, and we have the management. Good. Um, and this is just a picture of your aortic dissection, guys. Please know about Stanford and the Bicky. So your Stanford type A is where you have involvement of the ascending aorta, is either the ascending as well as descending or the ascending only. Whereas your Stanford type B does not involve the ascending aorta, right? So Stanford type B does not involve the ascending aorta. Stanford type A involves the ascending aorta, all right? And then it could further break down that into the Bicky type 1, 2, and 3. So just know this picture and know it well, all right? That's that. Any questions, guys, on AAA? Any questions on abdominal aortic aneurysm, venous insufficiency, or peripheral arterial disease? Are we clear? Okay, great. Yeah, that was a chunk. I'm tired. I have been tired. I still haven't oh my gosh, I still have not recovered from my call. Right? So I've been going. So let's get this over with and done with. All right. So the things that you all got correct, I will just read it out. You see a 65-year-old man in your clinic who's under surveillance for an abdominal aortic aneurysm. He smokes 20 cigarettes a day and has a 25-year history of poorly controlled hypertension. To monitor the progression of his abdominal aortic aneurysm, yes, you all were correct. The answer is ultrasound. If they asked you, what do you want to do to determine the need for operation, what would be the answer? CT scan. Excellent, right? So you all understand that concept. Fantastic. So this is a female patient, elective abdominal aortic aneurysm repair. If it's more than 5 centimeters in women, so A is the answer. If it's more than 5.5 centimeters in men. The other criteria for elective repair would be if it's growing at more than 1 centimeter per year or if the patient is symptomatic as a result of the aneurysm. Good. Number 14, which one of the following is the most appropriate investigation for the prompt diagnosis of an aortic dissection? Thank you for not choosing echocardiogram. Thank you for choosing CT scan. You are 100% correct. A transesophageal echocardiogram is not superior to a CT scan for aortic dissection. A CT scan is the first line investigation from diagnosis of an aortic dissection. So excellent. Good. Number 15. So a 56-year-old man with amaurosis fugax. So amaurosis fugax is where you have monoocular vision loss. Right? I should put sudden monoocular vision loss. Described as a curtain coming down. And it is transient. Lasts a few minutes. Okay? This is amaurosis fugax. What amaurosis fugax suggests? This is your guy here. He has a head. He has some thing here. This is his eyes here. You have a little eyes here. You have a little smile. A little teeth in the mouth here. Good. What amaurosis fugax suggests? Oh my gosh. What? Just now, guys. And to get this thing out of the way. Okay, yeah. What amaurosis fugax suggests is that this blood vessel in his neck, called his carotid artery, probably has some stenosis secondary to plaque. So what amaurosis fugax is where you have this plaque in the carotid artery. It breaks off, and it obstructs your retinal artery. So you have a microembolus breaking off of a carotid artery. It briefly obstructs your retinal artery and leads to your amaurosis fugax, which is your sudden monoocular vision loss that described as a curtain coming down, and it transiently resolves. So amaurosis fugax is in the setting of carotid artery stenosis. Okay, so that's for those of you who don't know. Now you know, and you will never forget what amaurosis fugax is. Okay, right? So this is carotid artery territory is the answer here. And therefore, to investigate for carotid artery stenosis, we would do a Doppler ultrasound. Carotid Doppler, easy question. Once you knew that the answer was carotid artery territory. Fantastic. Raynaud syndrome, this is just a reminder that Raynaud syndrome is precipitated by beta blockers. So C, beta blockers can cause Raynaud syndrome. Calcium channel blockers are used to treat Raynaud syndrome. So which one of these can be caused by which one of the following hypertensives could cause Raynaud syndrome? It would be C, beta blockers. Calcium channel blockers are peripheral vasodilators. Raynaud syndrome is caused by peripheral vasoconstriction. So if you vasodilate them, you will make them better. So that is why CCBs or calcium channel blockers are used to treat Raynaud syndrome. Beta blockers can precipitate Raynaud syndrome or Raynaud's phenomenon. Right? The answer here is indeed A. Good. So I just wanted you all to know to read up a little bit about carotid and end arterectomy. Guys, carotid end arterectomy has come once in the past. And I found it to be a very unfair question because I've never had exposure to it. But just read a little bit about carotid and end arterectomy. Okay? So I wanted to you all to get a little bit exposed to it. All right. Good. So yes, indication for a carotid end arterectomy is symptomatic carotid artery stenosis, where the carotid artery is stenosed more than 50%. Right? Number 20 is which of the following in a patient diagnosed with popliteal aneurysm, they are more likely to have an aortic aneurysm. Okay? So I think it's about 50% of patients with popliteal aneurysms have a greater chance of having an aortic aneurysm. So number 20 is C. Popliteal aneurysms are associated with aortic aneurysms. All right? And this last question, we all got wrong. Okay? Does anyone want to try again at number 19? So we can finish the class? Yeah, boy. Yeah. So actually, acute mesenteric ischemia, if you have a high index of suspicion, for example, if a patient is an arteriopath and they come in with belly pain, just belly pain and bloody diarrhea, not necessarily pain out of keeping with the clinical exams, but if they have belly pain and bloody diarrhea in an arteriopath and they have a high white cell count, they have a high lactate, they have a metabolic acidosis, any of that in an arteriopath with abdominal pain and lower GI bleed, that's a high index of suspicion for mesenteric ischemia that can help you make your diagnosis. So the answer to this question is actually E. Any of the above with a high index of suspicion. And in whom would you have a high index of suspicion? Your arteriopaths with atherosclerosis and peripheral artery disease, etc. Okay? Wow. I cannot tell you how exhausted I am, so I know that you are. Are there any questions, guys, on vascular? Was it good? I know it was a lot. Are we clear on these things? Excuse me. Fantastic. Thank you, Alia. Thanks, Lane. Okay. So before we go, couple things, right? I have confirmed when I'm doing my OSCE, and I will be doing the entire course online, and I will be aiming to have 1 to 2 days in person for demonstration of technique purposes for my St. Augustine students. But I cannot promise it. If I do that, it would come as like an extra thing. So there's that. The days that I will be doing it, I will tell you now, would be the ranging from the 7th of May to the 15th of May. Okay. So I will be having that internal medicine course. That's a separate course, and for you guys, it'll be 160 USD if you're interested. But I will be also having a class for the entire region on Easter Friday to kind of have a demonstration of what my OSCE is like. And because a lot of students have been asking me to sign up for the OSCE, right? Um, so I will be having that demo on Easter Friday for everybody, free to come, year fours, fives, wherever they are. But if you guys are interested and you are confirming it will be online March 7th to March 14th, it is fantastic. It can be done online. It's how I started teaching. You can message me and let me know that you're confirming. I have about 5 people confirming already because I spoke to them individually. There's that. The other thing I wanted to tell you all is that I missed out Endocrine Thursday, and I'm very sorry about that. I was extremely exhausted, but I will do it in pieces at the end or at the beginning of my further medicine lectures. So it's just adrenals and it's just parathyroid. So I will chuck in parathyroid probably at the end of renal, because renal I also do calcium a little bit. You have to speak about calcium when you're talking about kidney problems. And I will also do adrenal probably at the end of either hematology or root. So we're not going to miss out those things. The adrenals are extremely important. You all are going to get questions on adrenals, so I have to go through that with you. Parathyroid a little less so. Okay? So I just want to let you all know I will make up for it. I would not have a separate class. I would just incorporate it at the end or beginning of my other. I have like 4 or so medicine classes with you. Okay? So that's that. So if you're confirming OSCE, message me now. I will have that demo on Easter Friday. If you want to wait till then, that's fine. Otherwise, if you're surely interested, please message me now, because yeah, I know how it's going to be and I want you all to have first preference. Okay. Um, good. That is it about the updates of class. Oh, and the last thing is I will send you endocrine homework answers soon. I have to make some tweaks because I wanted to. Anyways, I have to make some necessary tweaks. Guys, make sure that you are reading through the homework answers. Great. All right, everyone. So take care. I will see you all on Monday, please God. Have a great night. Take care.